great. Доброго вечора, українські радіаційні онкологи, медичні фізики, радіаційні терапевтичні технологи. Слава Україні! Дуже дякуємо, що приєдналися до SBRT SRS course with Astra APM experts for Ukraine, Help Ukraine Group, Astra International Committee, APM Clinical Education Committee, Rise Contra Cancer with Sweet Care support. We are very excited to present the second lecture in the course. The topic is SBRT SRS commissioning and QA. We have an amazing speaker today with us, Professor Indran Chetty. He is Vice Chair of Research and Director of Medical Physics at Department of Radiation Oncology at Cedars-Sinai Health System. He previously worked at Henry Ford Health as Professor and Director of Medical Physics for 16 years. Dr. Chetty received his PhD in medical physics from University of California, Los Angeles, and after graduating, he joined the University of Michigan in 2000. In 2005, he was awarded NIH NCI R01 grant to investigate correlations of dose with outcome for patients with lung cancers. In 2007, he accepted the role of Vice Chair and Director of Medical Physics at Henry Ford Hospital, where he oversaw the clinical and research operations for a large group of medical physicists. He collaborated with team members on clinical translational research focused on image-guided stereotactic radiosurgery and body radiotherapy, SRS, SBRT, and MR-guided radiotherapy, resulting in several NIH and industrial partnership grants totaling over 14 million. That's very impressive. Congratulations. Over the past 5 years, Dr. Chetty research has centered on quantitative imaging, including applications of radiomics and other big data biomarkers for development of predictive analytical models to optimize therapeutic regimens for individual cancer patients. He's also actively engaged in the use of machine learning algorithms to automate processes for cancer treatments to improve efficiency and safety. Professor Chetty has published over 200 peer-reviewed articles and was awarded Wendell Anderson Endowed Professorship at Henry Ford Hospital in 2019. For his achievements, he was honored as a Fellow of Astra and Fellow of APM. Congratulations, Dr. Chetty. This is an amazing bio, amazing career you had, a lot of contributions to our field. We are very grateful, and it's an honor for us to host you today as a lecturer. Thank you so much for preparing this great lecture for us, and we're really looking forward to learning from you. So I'll stop sharing. The mic is yours.
Okay, thank you so much, Natalia, for the very nice introduction. Indeed, the honor is mine, really. I'm very honored and grateful to participate in this symposium, and thank you so much for putting this together and all of your advocacy. I mean, I think when I think about our lives and the problems we have, it pales in comparison to what's going on there, and we are very hopeful that this war will end soon, and we often think about all of you, and we wish the best for you and your families. So I'm very grateful, and I really appreciate the opportunity to do this for all of you, and hope you find it useful. So let me go ahead and share my my screen here.
Thank you so much for your kind words of support. Thank you.
Of course. I'm going to, if you don't mind, I'm going to turn my video off because of bandwidth.
Sounds good.
Let's go to show. All right. The topic is, as Natalia noted, SRS SBRT commissioning and QA. And I don't have any disclosures to report. Okay, let's begin with a definition and to just sort of a reminder for everybody that stereotactic describes a procedure during which a target is localized relative to known three-dimensional reference system, right? And SRS and SBRT, or sometimes it's called stereotactic ablative radiotherapy, or SABR. You'll hear this term from Dr. Timmerman and others. These are delivered in high doses of radiation in large fraction sizes, right? Over 10 gray, and short treatment courses, typically 5 fractions or less. SRS is defined as a treatment delivery to the brain or spine, and SBRT is defined as treatment delivery elsewhere in the body. Extracranial SRS is typically what we call spinal treatment. So let's begin with some data. And this was a survey that's a bit dated now. It's from 2011. And it was a survey of SBRT utilization in the United States. And they looked at 1,600 radiation oncologists' responses. They got over 500 analyzable responses. And so here's a picture of this. You see an exponential growth from, say, about 20% in 2005 to 65% in 2010. Well, if you look now with that exponential growth, we're talking more, in the region of probably 85 to 90% of sites that are using SBRT. The only ones that are typically not using SBRT as a standard of practice are things like head and neck, right? But for most other sites, you're seeing uh, use of some form of hypofractionation, and in many cases, it's generally 5 fractions or less. And if we look by site, we know lung cancer, medically inoperable early stage lung cancer, is sort of the standard of care. Spine is very popular, liver, and so other sites like pancreas, adrenal, prostate. Clearly, this is, from 2011, and today there's much higher utilization in all of these areas. And at some point, we'll get an updated survey on this data. But just to sort of illustrate that this is here to stay and it's becoming more popular. And it's very timely that we're talking about SRS, SBRT, quality and safety issues, and clinical utilization. So let me begin with a bold statement about safety, because that's fundamentally what our jobs entails is safety for patient treatment. At the end of the day, is the patient treated safely when we deliver the radiation? And we'll harken back to this very nice report that was put together called Safety is No Accident, a framework for quality radiation oncology and care. So sponsored by Astro in 2012. The authors were Dr. Zeidman, Palta, and Steinberg. And this came about, unfortunately, because of accidents, major accidents that happened in the U.S. And I'll go over some of those that was published in New York Times. You'll remember these articles from about 2009 through 2011. And they were eye-opening because of the detriment and morbidity to patients. And we as a field really got to feel what these patients were dealing with, to see some of the horrific images, and it was just very uh, uh, sort of eye-opening. It was like a wake-up call for the entire field. And so I think that there was a raw positive that came out of those events, and we'll review some of those aspects. So one of the things they talk about is this unprecedented expansion in the technological tools that we have available for our patients, which is a good thing. At the same time, there's this great expansion. We've added deep complexity to our planning and treatment delivery techniques, and I'll share some of that as well. But we've also seen a vigorous awareness about safety, not only from the New York Times articles, but in general in healthcare, right? We're becoming a lot more aware of mistakes and errors and how to improve quality and safety. So, if we couple all of this together, what we're looking for is sort of an integrated practice where we have teamwork, we have open communication, but where we have good quality procedures, quality and safety procedures that are simple, because we don't want to sort of mirror this complexity with complex procedures that can get dangerous. Um, so I highly encourage reading of this article. It's available on the internet. I think it's a very good resource. Complexity in SRS and SBRT. Why is it complex? Well, we're dealing with a small number of fractions. As I noted, it's 5 or less. So that means that setup uncertainties cannot average out as with conventional treatment over many fractions. It's high dose per fraction, right? It's generally, much bigger than 5 gray, 8 to 10 gray, 18 or 20 gray in some cases. So you must hit the target and avoid the surrounding normal tissues. We're dealing with small fields. SRS is 3 cm down to 5 millimeters or sometimes less. SBRT is generally less than 5 centimeters. So we're dealing with small field physics, which is quite complicated. All of this means that the beam model, target definition, dosimetry, dose calculation, and target localization must be highly accurate. You don't get another chance. You're giving a very high dose. Every aspect of your beam model, your treatment planning, your planning margins, your image guided setup has to be on target. No room for error. So it puts pressure on the entire team, not just the physics team. What happens if we don't follow careful procedures with small fields? Well, we run into accidents. And this was a very nice article that was published back in 2008 entitled Lessons Learned from Recent Accidents in Radiation Therapy in France. One of them impacted 145 patients. Patients were treated with brain tumors using 6MV with a micro MLC. The error was due to inaccurate measurement of small field output factors. So what they did was they used a farmer type cylindrical chamber with an air cavity of 0.65 cc. And, this is really, I'm hoping that everybody says this would be an unacceptable practice today. I think it's clear today that it would be unacceptable, but maybe back then it wasn't so clear. Nonetheless, it's a good learning opportunity for us. So we know that such a large volume chamber will suffer from significant volume averaging effects and will significantly underestimate the output factor, which goes inversely with monitor units, right? So in this particular case, it was a factor of 200% different. And here you can see the triangle showing the output factors measured with the 0.65 cc chamber. And if you used a correct chamber, a pinpoint chamber, 0.03 cc circles, you see the difference. And if you look, let's say, at a field size with 10 millimeters here, uh, you can clearly see 0.4 to 0.8, a factor of 2. So this obviously had some debilitating impact on the patients. But certainly there have been cases like this in the US. A US-based hospital in 2009 reported an error that impacted 76 patients undergoing SRS, overdosed by over 50%. Initially, they said it was due to miscalibration of the new equipment. More specifically, this was due to an incorrect volume ion chamber used to measure small field output factors. And so, as you can see from the picture I showed you previously, as you get smaller in field size, the error gets larger, right? Because of the small field problem and the volume averaging issue. Certainly, errors impact machines as well. This was a patient treated for an AVM, 6MV with a cone collimator. And sometimes as you know, we often use cones for things like trigeminal neuralgia as well. In this particular case, the error was due to sort of an issue with the units. The collimators should have been set to 40 by 40 millimeters. Instead, they were set to 40 by 40 centimeters. And it just amazes me that today we still have issues with this in our field. Like there's no consistency. When you say 10 by 10, what does that mean? Does it mean millimeters or centimeters? It's quite remarkable. Same thing with gray and centigrade. So I wish we can get to a point where we're consistent with our units, because I will tell you that the same thing happened in the US in a center that was reported in the New York Times. And in this particular case, I was privy to some of the information. And what happened was the therapist needed an override because they needed the jaw settings to be override when they put the cone in. And they called physics, and physics said, set it to a 10 by 10. And the physicist was referring to 10 millimeters, and they thought 10 centimeters. And the patient was treated with a single fraction, and I think the patient was severely debilitated or may even pass away, because obviously you have a significant amount of radiation if you're not collimating correctly. So again, it might seem like an obvious thing, but mistakes like this are still happening. So we have to be very cautious in how we define our units. Don't just say 10 by 10. Use the units, use the appropriate units. So I made some statements that small fields, we worry about complexity and, it might seem silly though, right? Like some of you might be thinking, well, what do you mean? This is an easy measurement. Well, it's not so easy, okay? And I'll give you an example of this. This was a survey of 40 identical SRS Linux with a field size of 6 by 6 millimeter fields defined by the MLC. And the ask was for all of these physicists to just measure the output factor. Okay, so here's the results of that. Okay, you see a 45% variation in the output factor measured for the same conditions on the same machine. So even though we might think this is straightforward, it's not so straightforward because as we get down to small fields, there are a number of factors that play into this that make it very difficult. So you're talking about things like very small differences in setup uncertainty can have big effects. You're talking about things like chamber calibration factors and perturbation factors that need to be applied when you get down to such small fields, and we'll review some of this now. So let's get to it, the physics of small fields. And fortunately, we have a lot of great reports at our disposal, starting with the IPEM, the Institute of Physics and Engineering in Medicine in the UK, that published the report number 103. The IAEA Technical Report Series, TRS 483, is a really excellent resource. Dosimetry of small static fields used in external beam radiotherapy planning. And then, as of late, we now have the report of the AAPM Task Group 155. So let's review some of this, and we'll use this report, the TRS series, as an example. According to this report, what is considered small? At least one of the three physical conditions will be fulfilled in order to be designated small. There's a loss of lateral charge particle equilibrium on the beam axis. There's partial occlusion of the primary photon source on the beam axis, and the size of the detector is similar or large compared to the beam dimension. So if you have any of these conditions, then you're considered small field dosimetry. So let's look at small field from the perspective of the photon source. So on the left, you see a large field situation. So if you're standing at the location of the tank and you're looking up in a large field, you will see the entire source. Okay, so you don't have any occlusion of the source per se. Now, in a small field setting, when you're standing on the tank and you're looking up, you see that the source is eclipsed. You don't see the entire source, right? So if you think about the output of the machine as being an integration over the length of the source, well, if you're only seeing a smaller source length, then your output's going to be lower. And you actually see that. You see a reduction in the output because you're eclipsing the entire source. Here's another picture of this and an impact on the profiles. Again, on the left, you have a large field setup where you're not eclipsing the photon source. On the right, you're seeing only part of the source, and as a result, you have this drop in output. And if you look here on the right side of this is in figure A, it's the large field case. In figure B, you're starting to get this drop in output. And in figure C, you're seeing for these really small cases, now you have a significant drop in output, but you also have interplay from the backup collimators and how the penumbra sort of adds to the penumbra of the MLC. And what happens is that you get this slight broadening of the full width of half maximum because you have this sort of summation of the opposing penumbra from opposing jaws, overlapping penumbras essentially. So what that means is that your definition, your physical definition of the source of the field size is not accurate anymore at these very small fields. So there's a number of different considerations that you have to keep in mind when you're getting to very small, and what by that I mean generally less than 1 centimeter. All right, I have a colleague in the UK, and they've written some really nice papers in Liverpool at the Clatterbridge Cancer Center. This is Professor Nahum. And he worked with a student to look at what really happens in the machine when you're getting to very small field sizes. So to do this simulation, they looked at a 6 MV beam with the full treatment head geometry. And so that's sort of the open diamonds here. And then the triangles are looking at a point source. So if you just consider the source as being a point versus the full geometry of the source, this is what you get is you get this triangle dashed line here. And you can see this is now in centimeters, so we're getting less than 1 centimeter here, right? But if you look at a point source or the full geometry, meaning a line source, you see that at about 7 millimeters, you get this sharp reduction in the output factor. And what they did was they scored kerma instead of dose. So remember now, if you're scoring kerma, you're only considering the energy that's given to the charged particles, and the charged particles are not transported, right? You're just transfer of energy from photon to electron, electron stops. So you're not dealing with any electron lateral scattering issues here. It's just photon. And you can see as a result of the occlusion of the source, at about 7 millimeters or so, you start getting this sharp reduction. So this is purely due to the occlusion of the source. So hence this paper is just validating the fact that you do get occlusion of the source. That's important. Now, impact on profiles and in your treatment planning systems. This was an experiment we conducted some years ago with the AAA algorithm and Acuros inside the Eclipse treatment planning system. If you change the default settings from 0 millimeters up to 3 millimeters, we did Monte Carlo calculations to validate. And you see that you have a fairly significant variation here for a 0.5 cm field. And that the actual width of the source, which is about 1.5 millimeters, is nicely predicted by Monte Carlo between 1 and 2 millimeters. And you see the same type of behavior with Acuros, albeit slightly different shape of these fields. Okay, so we are at question number 1. Hopefully you've been paying attention. Um, so which of the following statements is true at field sizes less than 1 centimeter? Is it A, lateral photon scattering decreases, B, lateral electron scattering decreases, C, beam energy decreases, D, effective photon source becomes occluded?
And we will wait to approximately 80% of them answering because that's how we take their attendance.
Okay,
We'll look at that
great.
answering the questions. Yeah.
So you tell me when I can go.
Yeah, I'll let you know.
Thank you.
I will do all the button clicking so you don't need to do anything.
Great.
But I will wait until approximately 80%. So we have 77% answering. I'm ending the poll and sharing the result. So most of you, 48% answered D, effective photon source becomes occluded. Do you mind commenting?
Yeah, so as I showed, as you I think the lateral photon scattering decreases and things of that nature is an electron interaction is a function of loss of charge particle equilibrium, which we'll get into next. But the big effect that I wanted to comment on was the fact that the major effect here is the effective photon source becomes occluded, which is something that we have to worry about for small fields as we get less than 1 centimeter.
Great, thank you.
Great. So let me, okay, okay, so there we go. And occlusion of the effective photon source, and I gave a reference there as well. Okay, so what can be done during commissioning? First of all, we need to make sure that we're selecting the appropriate detectors, right? And this is just a picture again for a 1 by 1 cm field measured with a bunch of different detectors like diode, diamond, pinpoint, 0.125 cc ion chamber, and then farmer chamber, just to show you the variation for two different energies, about how the responses of these detectors can change. Based on the type of detector. So importantly, select a detector with an appropriate active diameter and volume. This is some work we did at Henry Ford, looking at output factor ratios relative to the plastic scintillator detector for 6 MV photons for 0.5 and 1 cm square fields. The plastic scintillator detector is a factor of 1. And then you can look at the detector perturbation correction factors for these other detectors. You can see some of them can be large, on the order of 13% or so. Generally, for the diodes, they're usually within 5%. GAF chromic film was within a few percent. And then the Monte Carlo agreed quite well with the plastic scintillator as well. Now, I should note that when you're doing this in the clinic, an important reference here is the TRS, IAEA TRS report number 483, which gives you a comprehensive list of detector perturbation correction factors. So we always typically will use this as well, depending on the detector that we may have. But certainly there are many publications talking about this as well. We want to be able to compare data with that from other institutions. This is a paper we published back in 2013, where we had a collaboration with 4 different institutions just to look at the data that we were collecting for a TrueBeam machine. This was Henry Ford, it was University of Texas Southwestern, it was Washington University in St. Louis, and it was University of Colorado in Denver. So one thing to note is that even though different institutions can use different detectors, that you want to tailor them based on the type of fields you're measuring. So in one particular case, at Henry Ford in Colorado, we're using the Scandiatronics CC01 with a 0.01 cc volume for small field less than 3 by 3 and your photon output factors. You can use other chambers as well. For large fields, you can change a bit. You can use the 0.13 cc, which would be appropriate for fields greater than 4 by 4, as you can see there. And for small fields, UT Southwestern was using a different detector, PTW, but again, small volume, 0.015 cc. Now, if you're using diodes, certainly diodes are acceptable for small field dosimetries for your photon output factors and so on. But I will make a comment about diodes. There is an energy response, right? So what is recommended is what is called a daisy chain normalization, where you're normalizing the ratio of the output factors against a small field ion chamber at some reference field. And typically that reference field can be 3 by 3 or 4 by 4, but you do want to account for that. And then when you're doing your 2D dosimetry and verification, you have detector arrays. There are a variety of different detector arrays that can be used. I would say be cautious about spatial resolution, right? If your service is focused on everything SBRT or SRS less than 3 by 3 centimeters, then you have to be cautious about using detectors that have large detector spacing. So 7 millimeter detector spacing may not be appropriate. So you may want to tailor that and use something like GAF chromic film. Or nowadays, there are detectors which much smaller spacing. I think there's a new array now, that these radiosurgery type arrays like the Matrix and PTW has an array as well that has detector spacing on the order of 1 to 2 millimeters. So we have to be thoughtful and use some common sense about things like spatial resolution and tailor our measurements and detectors accordingly. Here are some of the results from the different institutions reporting, and you can see that in this paper the results were excellent for 6X, 6X triple F, 10F, 10X, 15X, there was about 1.5% variation at the 2x2 field, but in general, excellent agreement across the board. You see the same thing here for the profiles and the depth dose curves. And you will see some variation in the tails based on the type of detector. Again, if you're using a diode, the diode will tend to over-respond a little bit in the tails, right? So you'll get slightly higher response there. All right, so let's say now that we've acquired all our results, we've had our results checked, peer-reviewed, there are other elements that we need to worry about in the chain because it's a complicated chain. One of them is image fusion. So we're using MRI for radiosurgery. That's standard of care. We have to worry sometimes about distortions. And this was a paper that was published some time ago, but it illustrates the point nicely. And that is if you're using high field MRI, you do get distortions. Certainly, MRI has exquisite soft tissue contrast, but spatial resolution and spatial integrity is not as good as CT, and because of distortion. So you can see now here about a 2 mm deviation as a result of distortion. Now, we know that MR scanners today have excellent system distortion corrections, and generally it should be better than this, right, nowadays, but it's certainly very important to check. And we have phantoms that we can use to check. So this is the MR Fusion Lucy Phantom. You definitely want to make sure that at commissioning and probably even annually that you check your distortion corrections. A lot of times, we do not have MR simulators in our clinics. We're relying on diagnostic simulators. And look, the diagnostic physicians are not worried about spatial resolution as much as we are. They're worried about whether it's cancer or not. We're worried about where the cancer is located, right? So two different endpoints, and we have to make sure that spatial integrity and spatial targeting is 100%. Dose calculation. Small fields, this is an issue. It's a big time issue, and it's led to many mistakes and errors in the field, and it prompted the AAPM task group report number 101 to talk about this. So what they say is that algorithms accounting for 3D scatter, like convolution, superposition, Monte Carlo, perform adequately in regions, including many cases where you have loss of electronic equilibrium, such as lung tissue interface or tumors in the lung medium. Pencil beam algorithm should definitely not be used for lung cancer treatment planning. And they note further for small field, peripheral, island type lung lesions, algorithms explicitly accounting for electron transport, like Monte Carlo or Acuros, which is a discrete ordinance calculator, may be needed. So let's talk about the physics of small field. This is an example of a broad field on the left. So you have a nice steady state solution here. Meaning steady state, meaning if you take a small volume, the number of particle electrons leaving this volume is equivalent to the number of electrons entering the volume. You have a steady state. Another way to say this is that the in-scattering is equal to the out-scattering, right, from the electron dose deposition standpoint. In a small field, narrow field, this is what you have. You have more outscattering than in-scattering because you have this loss of side-scatter equilibrium here, right? So more charged particles are leaving than entering. And as a result, as this gets smaller and smaller, this effect gets worse. And so the dose drops, right? So you have this severe loss of CPE and lateral CPE in particular because it's really in the lateral direction that you're dealing with here. In addition, you have this scattering effect inside the lung tissue. So this is a Monte Carlo simulation, 10 MV pencil beam, looking at a slab phantom. So you have a water equivalent, lung equivalent, and then water equivalent, and your incident on this beam. And you're looking at the dose deposition on the central axis. And you can clearly see the scattering of electrons away from the central axis. Why? Because you have this low density tissue here, and this is a nonlinear effect. It's not just a simple radiological path length scaling, because at the end of the day, it becomes a combination of both small field and sort of lateral scattering of electrons. So Normally, the energy that would be deposited in this tissue is scattered away laterally, and hence you have a further reduction of dose in addition to loss of charge particle equilibrium from small field problem. So if you can combine these effects, it can be pretty significant. So what I'm showing here now is a depth dose curve, and it's looking at ion chamber in the same phantom, this long water phantom. So we looked at ion chamber and also Monte Carlo simulations, and you can see this significant reduction of dose, right? And as I noted, as you start getting into the lung, electrons are transporting energy away laterally, scattering, loss of CPE, reduction in dose. But then when you hit the water interface, you have this sort of rebuild up of dose because now the electrons have a range, right? But as soon as they hit the water, the density of the water increases, and hence they start redepositing dose. So you have sort of this rebuild up effect of dose. So this sort of shaded region here. And then you have sort of a reduction again, but fluent, because of lack of attenuation inside the lung from photons, you have a slightly higher dose in the rest of the lung. So how does this translate to a tumor? Let's look. So we've sort of made this situation now on the left analogous to a tumor on the right in 2 dimensions here, right? Um, and so here's your tumor, and here's your low density material. And like I said, as the electrons come in, they scatter laterally, but some of them that hit will start rebuilding up as they hit the tumor, right? And so you see this yellow region here is corresponding to this crosshatch region because the electrons have a range, and they stop when they hit the tumor because the tumor has density roughly equivalent to water density. So think about this rebuild up now. And as the tumor gets smaller, this rebuild up region stays the same, but the volume of it increases because the tumor got smaller, right? And eventually you get to a point where you're dealing with these coin lesions where now you're not even stopping electrons in the forward direction. So you only have partial deposition even in the forward direction. Hence, you have significant loss of dose. There's also an energy effect. So this is a Monte Carlo simulation on the left showing the range for 6x beam. See what happens 15x, right? The range of these electrons increases for 15. So your region of rebuild up is even higher because now these electrons will go further before they stop. So you have this sort of shadow effect, which is worse with energy. So let's look at a clinical case. This was a treatment planning system that was planned years ago. This planning system had 2 algorithms, the pencil beam algorithm. So when you look at the plan with the pencil beam, it looks wonderful, right? You have your GTV, PTV is covered at the 95% line. This is a small volume tumor, 15 cc. When you recompute with the Monte Carlo algorithm, which is also part of this planning system, you see what happens. You get a significant reduction. So now you're not even covering the GTV with the 80% line, let alone the PTV, for all of the effects I talked about. Lateral scattering, loss of CPE, and rebuild up of dose inside the tumor. Here's what the DVH looks like. This is Monte Carlo and pencil beam. You see the significant reduction. And you see it's differential, right? The reason you see it much larger here at the shoulder is because of this rebuild up. Eventually, as you get to the center of the tumor, you recover dose because you have electrons building up from the edge in toward the center, right? But the edge, as a result, the edge of the tumor is significantly worse. And if you look at the lung, the normal lung tissue, generally, because if you have this lateral scattering, the Monte Carlo is predicting a greater low dose spread. So you expect sort of more spread out of the dose inside the lung, and certainly the lower volumes getting higher dose. The energy effect, this was calculations we did in the planning system using pencil beam and AAA. And you can see for a 6 MV beam that you'd start getting this sort of constriction of dose, with AAA relative to pencil beam. Pencil beam always looks great, which can be quite deceiving. AAA, you can see sort of constriction somewhat. But then when you go to 18 MV, you see a significant reduction with the AAA. Again, pencil beam looks like everything's covered, but even with AAA now, you see a significant reduction. And this is all due to the range between the 18 MV and 6 MV. 18 MV range goes up, and as I showed in those previous pictures, this effect will get worse at the edge of the tumor. So we published a paper on this in 2013. We looked at about 150 cases, small field medically inoperable lung treated SBRT. These patients were given 12 gray times 4, so 48 gray to the 95% line, and we calculated them with a bunch of different algorithms, including the pencil beam 1D, pencil beam 3D, collapsed cone convolution, AAA, Acuros is included, and Monte Carlo. And here's the DVH comparison, and you can see the pencil beams are both showing, 50 gray, 12 times 4 to 95%. But when you look at the other algorithms, this is magnified scale here, you see that you have this significant reduction again, differentially more at the shoulders, um, and significantly reduced. But interestingly, they all generally agree with each other within about 3%, is what we found on average. AAA, collapsed cone convolution, Acuros, and Monte Carlo. All right, next question. Which of the following statements is true for treatment of small island lung tumors? A, dose to the tumor will increase because photon attenuation decreases in the lung. B, dose to the tumor will increase because photon attenuation increases in the lung. C, dose to the lung will decrease because of increased electron scattering. D, dose to the tumor will decrease because lateral CPE in the lung is maintained. Or E, dose to the tumor will decrease because of loss of lateral CPE due to combined effects of small fields and lung tissue heterogeneity.
It's a good question you asked.
Thanks. I hope it doesn't cause too much confusion.
You have to read it carefully.
Yeah.
All right, so we have 81% answering. So I'm ending the poll, sharing results, and most of you answered E. 44% answered E. Dose to the tumor will decrease because loss of lateral CPE due to combined effects of small fields and lung tissue heterogeneity. Would you mind
Okay.
commenting? Yeah.
Yeah, absolutely. Yes, so the answer is E, because if let's go through the answers. Dose to the tumor will increase. No, it will decrease, right? We kind of went over this. Small island lung tumors, the tumor will always decrease. So what about dose to the lung in C? Dose to the lung will increase. I just showed that because you have lateral scattering. Generally, the low dose volumes go higher. And then, so we have options D and E. The dose to the tumor will decrease because lateral CPE in the lung is maintained. No, that's not true because you lose lateral CPE at the small fields. So the option is E. Great, and I gave a reference there. So let's move on. All right, so we talked about commissioning, we talked about beam models and treatment planning. Well, there's other things we have to worry about that might seem obvious, but you do have to account for them. One is commissioning of the 6D robotics couch with rails. And depending on the type of couch, we have a variety of different couches that we have available for linear accelerators, including the standard variant IGRT couch. You have something called a K-View couch, which if you're using things like Calypso, which is the electromagnetic tracking then you need this special type of couch. You may have true beams with different couches in your department. So the important note here is that there are couch models inside planning systems like Eclipse. And one of them that we put in years ago was for a K-view couch. Importantly, this couch has these rails that go in and out. So you do have to worry about that because the effect is not insignificant. Depending what angle you're radiating from, so see around 110 degrees or so here, you see a significant drop, 13%, because of the rails. And this will also vary between rail positions. So if your rails are in versus rails are out, then you see a variation there as well. And all of this depends on where the rails are located because as you sort of rotate gantry angle, depending on the angle, you could go through more or less of the rails, right? So just something to think about. You have to do these measurements to validate. MLC is of significant importance, clearly. So there's some tests here that we referenced some years ago. We have the typical spoke shot film, the picket fence analysis with the EPID imager or with film to look at how well your MLC positions are doing. This should be done regularly to check that your MLCs are hitting, positions are hitting the target. Of course, the Winston-Lutz test is paramount to checking the isocentricity of the gantry collimator couch. And we did this in a paper we published in 2014 where we looked at the daily variation in the Winston-Lutz test results. And you can see the daily variation can be up to a millimeter in some cases. On average, it's about 0.65 millimeters for the maximum deviation. For the average deviation is generally around 0.2. And you want this to be as small as possible. In some cases, you may need engineers to come out and actually move your isocenter or adjust your couch to get within tolerance for each of these parameters. What about image quality? This is key. I think it's understated, the importance of image quality, right? As physicists, we're worrying about, 1%, 1 millimeter, half percent. But then we say, here, we give the patient to the therapist and say, treat the patient. And so, if things like your image quality are not good, then they don't have the tools that they need to maintain that 1%, half percent accuracy. So how good is the image quality? There are a variety of phantoms that you can use. The Leeds phantom, Las Vegas phantom, a few others, basically showing things like checking the low contrast detectability, the spatial resolution. You can do more quantitative experiments like the MTF or the DQE, the modulation transfer function. And then you want to check things like your Hounsfield electron density conversion using this type of phantom as well. So a very important component of commissioning are these hidden target tests, where you're starting with a target at the time of simulation. You're doing your simulation and image guided setup, and then you're localizing. In this case, it's these hidden targets, so you're just localizing to find the target, right? So in this particular example, we did that with BBs on a phantom. We looked at the stereoscopic imaging from the ExactTrack BrainLab system, and then we looked at cone beam CT as well. And then to look at the residual errors, we looked at the AP lateral film alignment relative to the initial setup with either the floor-mounted X-ray or the cone beam CT. And here are the results of that. For the translations, you can see using the stereoscopic X-rays, good within about a millimeter, and then comparing that independently against cone beam CT. The one deviation was a bit more, which was higher in the SUP-INF direction, but within a millimeter. Vector length is about roughly the same between the two. This kind of thing this difference in the SUP-INF direction can indicate some systematic difference between the two systems. And then if you look at the rotations, the 6D robotics, you see 19 of 24 cases were within plus or minus 0.3 degrees. Maximum deviation was about 0.7 degree. The dosimetric impact of rotations is also important. We looked at 711 ExactTrack 3D, 2D registrations. And we looked at the distributions of these rotations. Most of them occurred between 0 and 2 degrees, but you certainly get some at 2 to 3 degrees, and then others, smaller percentages, obviously 4 to 5 degrees. If you laid on one of these tables, you find that at 3 degrees, it feels like you're falling off the table. So you wouldn't necessarily rotate to 4 or 5 degrees. You may go up to 3 degree, but that's a red flag that something strange is going on. You have to look at your entire setup. So here's the impact on the dosimetry. This was a spinal cord lesion. In this case, on the left in the plan, 10% receives less than 10 gray, but with a 5 degree rotation, which is a larger rotation, you have now 40% of the cord receiving 10 gray, so you're clearly violating your constraints. Some of this depends on, the length of the lesion you're treating, just geometrically how this is rotating. And so in some cases, depending on the length, even a smaller rotation can give you a large deviation. So it's important if you have something over 2 degrees that you check it very carefully. Typically for radiosurgery, it's less than a degree or even half a degree that you're setting your tolerances for. End-to-end testing is equally important. So in addition to your hidden target tests, you want to look at dose as well. So the end-to-end is starting with imaging simulation, then you're going to image-based localization or treatment planning, image-based localization, and then evaluation of planned and delivered doses. So there are a variety of phantoms. This is done in the Lucy phantom and using the test suite from AAPM TG119. There are a list of very nice cases that you can use there that vary in complexity, and you want to check against the range of different levels of complexity. If you're doing heterogeneity, you also want to check those. Again, this is from the TG119 suite, looking at a spine type lesion or a heart, they call this the hard C shape. And it's a fairly complex shape, but you want to check, validate that you're doing the right thing with regard to measurements, which is key. Tissue heterogeneity, you have phantoms to check this as well. This is what we included in the 2013 paper for the TrueBeam commissioning. I will say that you can sometimes tailor your external peer review auditing, end-to-end testing based on the type of treatment. So if you're not doing, let's say, cranial radiosurgery and you're just doing lung SBRT, then you don't need to use all the phantoms. You can use the lung phantom, but make sure that your commissioning data is accurate as well. So you can tailor depending on the type of service you're offering.
Did you do this with motion as well?
Yes, so I didn't show all of the results, but you certainly want to include motion in your 4D evaluation. That's a standard part, including things like gating, latency, and so on. So here's a sort of an example of the phantoms that are available for independent verification from the IROC, which is the MD Anderson in Houston that we have available here. The variety of different phantoms that you can see, brain, spine, thorax, and so on. And so I always recommend, certainly we do it as part of our best practice here, anytime we're commissioning a machine where we're doing things like SBRT with tissue heterogeneity, we will sequester the IROC phantom, we'll do the measurement, and we'll submit results before we go clinical with the machine. Okay, that brings us to question number 3. Which of the following statements is or are not considered best practice for commissioning small field data for SRS SBRT beam models? A, if using a diode for small field output factors, a daisy chain normalization against the small ion chamber is recommended at a reference field. B, end-to-end testing must be conducted. C, if you have checked and rechecked your small field measurements, no peer review is necessary. D, image registration and fusion uncertainty should be carefully reviewed and incorporated into the planning margins when necessary. Okay, go ahead.
And so this is just a reminder that it's not considered best practice.
Correct. Not considered best practice. I made like board type questions. Sorry about that.
No. Yeah. Are you aware of the Phantoms available in Europe? So we were talking about IROC Phantoms here, MD Anderson, Houston, but do you
Yeah,
know
I'm not
what
sure.
phantoms are
I'm
used for
sure
SRS?
yeah, I'm sure there are available I guess I don't know the analog to the ADCLs in Europe. I'm sure your ADCLs there would have phantoms available. There's probably some in the UK and other countries, right? Are
Mhm.
you familiar, Natalia, or no?
I am not sure, so
Yeah.
that's why I'm
Yeah.
asking. So
Yeah,
if you heard
unfortunately,
about
I'm not. I'm
SRS,
pretty sure the UK has ADCLs that have phantoms like this, but I don't know exactly how that operates in Europe.
right?
So apologies. I could have checked on that, I guess.
No,
Sorry.
no worries. Yeah, I was just curious. So we have 76%, 78% answering. I'm ending the poll, sharing the result. Most people answered C, 58%.
Okay, great. Well, C is the correct answer. So, a nice resource is the AAPM MPPG 9.A SRS and SBRT published in 2017. And that document is going through an upgrade or update right now,
Mhm,
and it'll be released soon. So, just to kind of remind you, as many of you realized, when you're using a diode, you want to do a daisy chain normalization because of the energy dependence. You must do end-to-end testing. See if you have checked and rechecked your small field measurements. That's not good enough because we all will have our biases in doing measurements. You definitely want to have a peer review from either a colleague in your institution and preferably a colleague from an outside institution to review your results. Certainly D, image fusion and registration uncertainties, you must check those and you can incorporate those into your planning margins and using the Van Herk formulas, for instance.
mhm.
It's a very important part of our practice to ensure that things are done safely. All right, so I want to spend now the next part of this lecture talking about safety and the culture of safety because I think when we think about how safety operates and how we work in safety, we are working uh, in conjunction with other team members. We're not just working on an island to treat cancer patients. So even though we may be attuned to all of the technical factors that are needed to deliver treatment safely, we're relying on the competency of everybody else around us to get the job done safely. And as a result, we're working in an environment, in a culture, or in a village, if you like, of quality and safety, right? So let's talk about that. We know that the goal of radiotherapy is simple: optimize the therapeutic ratio, put as much dose into the tumor while minimizing as much as possible normal tissue dose. But we're doing this with very different types of cancers, different treatment techniques, several different technologies, multi versus single vendor environments, research environment, clinical environment, physicians, physicists, therapists, dosimetry, IS, IT, administrative staff, nurses, things like that. And then technological innovations. We have all kinds of tools at our disposal, EPIDs, different imagers, now MR guided systems, PET-based systems, online, offline approaches. So what it means is we're working in a very, very, very complex environment. And to come back to this idea of complexity, clearly, I hope you all agree that it's not straightforward, it's not simple, it's complex. And here's an example of a very complex treatment machine. This is an excellent machine because you have every tool available to treat almost anything you want. It has, 60 robotics couch. It has stereoscopic X-rays. It has MV EPID, KVOBI. And then you have multiple photon energies, flattening filter-free modes, electrons. We have a high definition MLC. And you're familiar with this machine. It was a combination of two vendors. So we had the Exact Track systems from Brainlab. We had the Varian systems, and this was called a Novellix TX machine. The 6C couch was controlled by the exact track, and then you also had uh, an insert that was controlled by exact track, and then 60 controlled by the cone beam CT on the variant side. And I'm familiar with this machine. It was an excellent machine. We used it. We installed one of the first in Detroit in 2010. But I will tell you that it is a very complicated machine because you have these two different vendors that don't always talk to each other, right? And a good example of this is what happens when you have an upgrade, when one system is upgrading and the other system's not upgraded. So you now have settings in the upgrade technology where you have to account for things that are changing in one system but are not in another system. And I can tell you that there have been mistakes in this type of environment, not this necessarily this specific machine, but multi-vendor environments where upgrades have happened and one setting was not checked. And as a result, that impacted patients over 6 months in one particular case because there were two different vendors that were involved. And there was an upgrade. So interconnectivity is problematic when you're dealing with multiple vendors. And it's really incumbent on the physicist to make sure that every single setting is the same, is not impacted when these upgrades happen. And sometimes it's not even straightforward to do this by checking things like files, file changes. You actually have to go in and do some measurements to validate that these settings have not impacted the delivery of the delivery specifications of the machine. So getting back to the safety is no accident report and complexity and how we should go about this. There were several areas that were highlighted. One was system interconnectivity. As I mentioned, I harped on this because there are mistakes that have happened um, in the U.S. as a result of system interconnectivity. Error and near misreporting. We want to encourage this to detect and facilitate widespread dissemination of alerts when problems occur. We do have an incident learning system called Royals here, the RO Incident Learning System. I encourage you to develop one if you don't have one or purchase one at your institution. This is a very good practice to learn about mistakes that are happening. Education about safety. AAPM Astro developed a series of white papers focusing on SRS and SBRT and other technologies. So again, look at the peer-reviewed research that has been published. There are lots of guidance from the Astro and AAPM. And then patient advocacy. So it's important that patients understand the technologies that they have available, that patients themselves are aware of potential incidents or accidents that occur with different technologies. And we want to share information openly so that patients can have the best information they have available when they're making decision on this important life-changing treatment that they're going to get for their cancers. So looking a little bit more at some of the errors, there's a paper that was published looking at types of errors that can occur. This was a list of radiosurgery errors that were reported from the NRC, the Nuclear Regulatory Commission, during the period 2005 to 2010. The Nuclear Regulatory Commission also has a process whereby any error has to be reported openly and publicly available so that everybody can see what happened and learn from it. So a few different examples. So one was facial nerve target instead of trigeminal nerve, wrong location. A fair amount of wrong location type things, but certainly dose, physicists calculated prescription dose to 50% instead of 40% as an example. So things to just look at and to learn from. So this was from Peter Dunscombe, who's sort of been a giant in quality and safety in our field. Really helped spearhead the culture. He was Canadian, but they looked at in Canada the incident learning system in Calgary, and they compared that to the radiation oncology safety information system, ROSIS, which is your European version there, and they found quite similar results. So things that were due to standards, procedures, and practices was over 50%, certainly more like 60 to 70%. But then other areas, communication, planning, you can see very similar trends here, right? About how these errors can occur. And in order for us to improve, it's important that we look back to see what was going wrong in the first place, right? So that we can tailor our practices to address those issues and be more proactive toward them. So human factors is dominant. 60 to 80% of incidents had something to do with policies and procedures, which is dominant, where something got missed by the human that was interacting with these procedures. Human factors engineering approaches, including methods to improve behavior, attitude, enhance education and information to improve human performance, is critical toward improving safety. So, noting that 60 to 80% of these incidents is due to human processes, if we build our systems to make them robust to these procedures, but in order to do that, there's an entire field devoted toward human factors engineering. So an example is, how do you develop a control system at the treatment unit with this in mind, with human factors in mind? How do you make a system that is sort of built in a way that it maybe takes the human interaction a bit out of it so that the error rate can be improved with regard to human factors? All right, so the next question. Which of the following statements is or are true? A, complexity can increase the chance of errors in radiation oncology. B, interconnecting systems and interfaces can increase the chance of errors. C, analysis shows that the majority of errors are related to human factors. D, investing in human factors engineering approaches can improve safety. E, all of the above. Okay, go ahead.
It's a very nice question.
Thank you.
Right, so we have a 78%, 81% answering now, and majority of you, 88% answered E, all of the above.
Wonderful. Because he is the correct answer. Wonderful. So I'm actually very pleased with myself because I think I've been looking at the scores and they're getting better, much better as
Good
my
job, yeah.
presentation goes on. So I'm feeling good. Initially, I was getting quite nervous because I was thinking maybe I'm not doing a good job here.
No, you're doing great. Amazing.
So, so I'm really glad. This is great. Thank you all. And so, clearly all of the statements are true. Complexity, interconnecting systems can increase chance of errors. Most of these are human factors, and of course, investing in human factors can improve safety. So he is perfect, right on. So here are some best practices, again, from the Safety is No Accident report. And I want to give out a shout out here to my colleague and friend, Dr. Larry Marks from University of North Carolina, who's been a physician that has really been a champion of the safety culture. And, safety is not always something, and quality is not always front of mind for clinicians, right? They're busy, they're treating patients, they want to get patients treated and do the best they can, but they're not always thinking about different approaches that they can use in their practice to make things safe. So, what Dr. Marks says is that safety culture is best driven from the top. The leadership must consider it a priority. So, if the department chair and the head of physics and other leaders are not taking it importantly, then the team may not feel like this is an important thing. Just think about this in our day-to-day interactions. We follow our leaders, right? We act like our leaders, and we want to follow what our leaders are saying are important in our clinics. So it's imperative that the leadership and the system leadership views quality and safety as important. We want to acknowledge that there's a problem in the first place, right? If we think that everything is wonderful, sunshine and rainbows, then we may not think that that we need to do anything above and beyond, which is where we become complacent, and that can lead to mistakes. We want to be able to speak openly. So everybody has a voice. Everyone should have a voice, whether it's the therapist treating the patient or the physician doing the contouring. Everyone should say, stop the procedure, I'm not comfortable. We want to empower and support others. So we want to celebrate accomplishments, and we want to help our colleagues and bring them up in a nice, supportive environment. We don't want to dictate terms to them. So we want to enhance education. These are mortality and morbidity conferences, safety rounds, QA meetings, departmental safety retreats, huddles, those kind of things. Incorporate safety into all departmental activities. Change is hard. And if you're in an environment where safety wasn't top of mind and you want to change to your culture where safety is top of mind, it's not easy. It takes the entire team. And as I mentioned, it takes a village. Earlier, we talked about a village that we all work in every day. And we all have to support each other and celebrate each other and help each other in this village. Uh, and it may not be easy because not everybody may be aligned, and not everybody will be at the same level of engagement. But if we all work together, if we all unite, then we can accomplish something that's bigger than what we're trying to achieve, right? So here are two example models. One is a hierarchical model. So even though we want our leadership to say it's important, we don't necessarily want our leaders dictating terms and policies, because the leaders often are not involved in the day-to-day operation. We want the team members to develop procedures. We want leadership to say, this is important, but we won't want leadership to dictate the terms or to be reactive in terms of error. So, we don't want leaders to say, there's a big mistake happened, I'm firing person X, Y, and Z. That's just not good leadership, and it's not sort of a proactive, system-oriented approach. It's sort of a dictator problem, which is not something that we want. We want more of a collaborative model in the clinic, right? Where we now go from a bottom up. So where the people on the ground level are working with leadership to develop the procedures and the policies and nurturing a culture of safety. And we sort of, when everybody's engaged, then we have an ability to integrate and to listen to everybody and build the most robust procedures that we can have. So checklists are very important, and I will tell you that these are two excellent books. One is called The Checklist Manifesto, How to Get Things Right, by Dr. Atul Gawande at Harvard. And the other one was Save Patients, Smart Hospitals, by Dr. Pronovost at Johns Hopkins. Checklists have really transformed medical care in the United States and across the whole world. And if you read these books, you'll realize some of the examples of how that was done. So checklists are key to everything that we do. Checklists should be developed from detailed procedures to ensure that a given process is implemented accurately and consistently. But we also want to make sure that the checklists are not exhaustive, right? So in other words, if you're just doing a patient chart check and you're checking every item against a checklist, you might get exhausted and you may miss, as they say, miss the forest from the tree. So you're sort of dealing with all of the granular activities, but you're missing the big picture, such as, is this the right patient? Do the monitor units make sense? Those kinds of big picture checks are important in your checklist procedures. Your checklist must be precise, to the point for effective implementation, but comprehensive to encompass aspects of the procedure. They must include big picture items, as I noted. So one good example that I will share with you is that if you've ever been on a plane, a small plane, the 6-seater Cessnas, they have checklists like with it on every plane. But if you look at the checklist on a Cessna, one of the pages just says, fly the airplane. That's it. That's the only thing written on that checklist. And the reason for that is that the realization that if there's an error going on, there's an influx of information to the pilot. They're getting all of these beeps showing up, these lights turning on, and there's like 100 things going on, and it can be so distracting that sometimes they just forget to fly the plane and the plane crashes. And they put this checklist in place because of accidents that have occurred where the pilot forgets that they're losing altitude and the plane crashes. So, to the point, don't make your checklist so exhaustive that you're missing the big pictures. You must have a few big picture items that say, okay, this is making sense. Yeah, we're treating the right side of the patient. We're treating the right patient. The monitor units make sense. We're using the right beam energies, those kinds of things. So, in an analogous way, uh, look at the MLC. There's a mistake that happened in the US at an institution of one of my colleagues where they were walking by after the first week of treatment and they realized for a complex head and neck treatment that the MLCs weren't moving. So a patient received a week's worth of treatment with just open block, open jaw, because this happened some time ago in a system where mistakes could happen with transfer. There were two modes. There was QA mode and there was treatment mode. The physicist had done the QA correctly the day before when the MLCs transferred. Somehow, when the patient plan was transferred, the MLC didn't come across properly. And the therapist missed it, and it took somebody walking by to say, hey, wait a second, something's not right here. So, make sure that your therapist, when they're also engaged in doing multiple things, that are paying attention to what's happening from the big picture. Are they watching the patient? Are they making sure the right patient's on the table? Those kinds of things. Okay, so final question. Which of the following statements is or are false? A hierarchical safety model can generally result in a better safety culture than a collaborative model. B, checklists are important for safe operations, but one must be aware of checklist fatigue. C, most errors result from intentional mistakes rather than problems with processes. D, safety culture must be emphasized by leadership. E, A only, and then F, A, and C only. So this is my most complicated question, I think.
Yeah, it's a tricky one. And just to let everyone know again, you have to answer what's not correct, what's false.
Yes, which is false.
Mhm. I think they're doing great.
Great.
I like how you put a big emphasis on safety, and I think it's very, very useful for Ukrainians because I think there's still this hesitance to report errors, and um,
Yeah.
especially in the public systems like Royals or Safran, there's an equivalent from
Mhm.
IAEA, Safran system,
Definitely.
but not many Ukrainian cancer centers participate in it.
Yeah. But that's true even in the US. It's probably in
Yeah,
the
true.
majority of institutions where it's hard to report errors because people are afraid of being in a punitive environment.
Yeah,
So this is not uncommon. It's something
yeah.
that we have to keep messaging, I feel.
True, and you delivered the message very eloquently. Thank you.
Well, thank
So
you.
83% answered. We're ending the poll and sharing the results. So majority of you, 61% answered F.
Fantastic. Because F is the correct answer. Excellent. Well, we can review this really quickly. So I just reviewed this. I mentioned the hierarchical model where you're saying hierarchy, top down. You want leaders to say safety is important, but you don't want leaders to build your safety culture because that can be bad. So that answer A is false. Collaborative model is what you want to build a good safety culture. B, checklists are important for safe operations, but one must be aware of checklist fatigue. That is correct. We talked a bit about this. C, most errors result from intentional mistakes rather than problems. No, you certainly can have situations with individual people that are demonstrating behavior that are sort of below the line where they keep doing intentional things. And of course, you want to address that. But for the most part, from the data, the problem exists with processes and procedures and how humans interact with these systems uh, in place. D, safety culture must be emphasized by leadership is correct. So E, A only, A is a correct answer, but it's not the only correct answer. So that's why, sorry, I tricked you a little bit. A and C is the correct answer. And I gave the reference here for the SRS safety is no accident report. All
Excellent.
right.
Thank you.
So in summary, hypofractionated treatment using SRS and SBRT techniques require high levels of accuracy in patient simulation, planning, and treatment delivery. Commissioning and beam modeling data must be done with utmost care to ensure measurements done accurately in the small field setting. Peer review of data is strongly encouraged. Treatment planning and dose calculation accuracy must be done with knowledge of small field dosimetry. A safety culture supported by leadership in a non-punitive environment is really critical toward promoting safe patient treatments. Image guidance must be done diligently and based on motion and setup uncertainties. Planning margins must be evaluated and adjusted as needed. So, overall, I hope I've given you the sense that there are multiple elements that need to be considered carefully. I think that just by nature of us being physicists, we are very diligent. We want to do the best we can in the technical setting, but realize we're working with other team members, dosimetrists, therapists, and physicians, and we need to be open in our communications and our expectations of the technical accuracies, but also in the culture of safety. And we want to try to work toward each other, toward with each other toward a common goal. And that common goal is that the patient's on the table, and are we all satisfied that we're delivering the most accurate treatment we can for that patient on any given day? We certainly all have uh, family members or even personal circumstances where we've had to go through treatment, and we know how we feel when we engage with providers. And so we want to be empathetic and we want to put ourselves in the patient's shoes and realize that uh, there's a patient here going through cancer treatment and that we ought to be doing our best. But again, it takes a village. But if we do our part and communicate how things should work, then that gives us an opportunity to be leaders in this space. And I think just the way we operate as physicists, our mindsets, we're really positioned in a good place to be leaders with regard to quality and safety in radiosurgery and SBRT, but for everything in the clinic. So with that, I'd like to thank you for your attention and thank you again for the wonderful opportunity. And thank you, Natalia, for just being an amazing a leader in this space and for everything that you're doing for the people in Ukraine. Thank you.
Oh, that's great. Thank you so much for such an amazing lecture. This was really inspirational, and I love how you encourage everyone to be leaders in safety, collaborate, communicate, to make patient treatment safer, more precise. So this was really excellent. Thank you so much. So I am opening the floor for questions, and we see really a lot of thank yous, great lecture, comments. I'm going to read the first question from Dr. Nahirnyak. Dr. Chetty, what was the main reason in developing this technique, SRS SBRT? Was that primarily a financial reason? For example, less fractions means less time spent per patient, more patients per day treated, and eventually greater profit for hospital, or was it something else?
Yeah, I think that's a great question. It's a really excellent question. I can speak on a few different fronts there. I can tell you that, at least from my experience here in the US, SBRT didn't necessarily start because of financial ramifications, right? It started because of outcomes, right? And if you think about the history of it, we started with radiosurgery. Everybody knows
Mhm.
Lexel approaches and all of this way back when. And that was effective for things like brain tumors, right?
Mhm.
Because you were able to give very high doses, small volumes, avoid normal tissue, ablative doses. But then, if you look at the history, Japan, countries like Japan started using this very effectively in the 90s, 80s, and 90s for things like lung tumors. And some of the investigators here in the US, like Dr. Timmerman, uh,
Mhm.
spearheaded, picked up on some of the clinical trial results that were coming from the folks in Japan and showing that, wow, this could be something that could be beneficial to our patients in the US. And really took it. And I mean, Dr. Timmerman himself was a pioneer in terms of working on fractionation schedules and things like this. But you could argue, well, why all of a sudden is it working now, and why did it work previously in the, prior to the 90s when this was becoming popular? Well, a lot of it had to do with the radiobiology and the fact that the imaging techniques and the ability to reduce margins, right? Way back when we were using large fields, 4 field boxes, we didn't know where the target was because we didn't have the right imaging. We didn't have 3D CT imaging at the time. So everybody was using big margins. And when you use big margins, you cannot give high doses without being lethal to the patient. So as a result, we couldn't do it, and it was just too the toxicity was too high. So then, as we started developing this and learned from other countries on how to sort of incorporate it with better imaging, then we got cone beam CT in early 2000s. That really changed the game because it allowed us to reduce margins. So now you can take a tumor that you used to treat with a big field and really shrink the field, and now you can target the dose. So that's kind of how it started. And I think, Dr. Timmerman, to his credit, really just pushed the envelope. He drove this technology for long. The outcomes were amazing, 90% or higher for early stage.
Mhm.
It was a rival to surgery, right?
Right.
And
Yeah.
then other sites started following suit and realized if we can image and reduce our margins, we can actually increase the dose. Now, to the other side of that question, which is the financial ramifications, 100%. Hospitals are jumping all over this. Administrators jump all over it because they're like, oh, it's only, we could only, we can treat now with 5 fractions. But remember, the reimbursement system in the US doesn't necessarily favor big reimbursement that way because the way we get currently we bill is by for every click, right? So every task
For every fraction. Yeah.
yeah, every fraction is billable. So if we go down to a small number of fractions, our reimbursement goes down significantly. And that's currently how it's not bundle payments yet. Now, there is a bundle payment model that's on the docket. We don't know when that's going to get approved by Congress. I mean, as we all know, what's happening in the US, right?
Yeah.
It's extremely unpredictable, but so it doesn't help us. But in order for administrators to manage costs would reduce reimbursement, they do factor in the fact that now it's cheaper for us to be able to deliver its treatment. The one thing that is missed in this equation is the technical piece of it, because delivering SBRT treatment is much more technically complex than 3D or IMRT. We all know that as physicists. The administrators don't build that in. They do not factor that in. And it's up to us as leaders to say, that's wrong. We have to hire more physicists to do this
Mhm.
because at the end of the day, this is more complicated. And all it's going to take is one mistake for you to really close your program down. So I'm often getting in fights with administrators because they don't understand. They're like, oh, physicists, they're in the back, they're just doing their thing. Well, the more SBRT we do, the more work it is for us. We get fatigued and we have to support increased staffing levels, which in the end is going to cost more, right? So it's a very complicated balance of a variety of different factors. Yeah.
Dr. Chetty, in your clinic, do you have physicists attend every treatment, SBRT treatment?
Yes.
Yes. Okay. And
Yeah.
they are there for the whole duration of the treatment.
Yes.
And
Yeah. They
physician
do.
as well?
Yes, so the physicians come in to approve the volume,
Images.
the
Hmm.
images, yeah.
Hmm.
Yeah, and the physicists will often stay there in case something happens during treatment
Yeah.
for the treatment procedure, but oftentimes they're not required to. They're just
Hmm.
required to be there with physician to check. But we do have a physicist there for every SRS and SBRT
Okay. So
and
same.
simulation and at time of simulation.
And simulation. Oh,
Yes.
that's a big commitment.
It is, but it's
Yeah.
something that we feel is helpful because at the
Hmm.
time, if you set things up right at the time of sim, makes it easier down the chain.
Excellent. That's great. I have a question about the MR distortions. You showed a really nice slide with Tim Salzberg's work showing that distortions can really affect how we contour the target, see the target, how the delivery goes, right? So I'm just wondering how you practically check distortions if you are utilizing MR simulate or MR machines throughout Cedars-Sinai, right? How can you control the quality assurance for
Yeah, that's a
distortions?
great question. And so I think this is where you can have an opportunity to collaborate with your partners in imaging. We do
Uh-huh.
have a good collaboration with our imaging physicists. And
Mm-hmm.
so I haven't done this specifically here yet, but at Henry Ford, for instance, we would have phantoms where we check, we have them check. And, you know, depending on where you're at, you can also tailor it so that you know which machines you're targeting. You're getting your MRs at your main campus or other centers and
Mm-hmm.
try to, optimize that workflow where you're limiting it to, some number of scanners that can be checked regularly. But if you're working closely with the imaging physicists, you could even say to them, hey, the next time you do a QA, can you run our Phantom? And they're often happy to do that.
Mm-hmm.
In fact, they're even happy to come down and do uh, dose calibration on your CT simulators. So I think a lot of this is just, finding a pathway to be able to communicate effectively with them.
Mm-hmm. That's great. I think that's something we are struggling with because we have a huge network for Mars scanners, and we actually hire a company to do the quality assurance. So the radiology department is not necessarily doing this. So
I see.
it's a bit of a challenge, but that's
Yeah.
specific to us. So I see the question in the chat from Leonid Kratzul. What do you think about introducing extra checks on daily QA only on days with SRS SBRT patient treatment? Something like requiring Winston loss test on that day before starting the treatment. What other checks can someone introduce that won't make a difference during days without SRS SBRT that could provide useful information on days with SRS SBRT patients?
Yeah, these are all great questions. So in our practice, we do have a procedure where we do the Winston Lots on the day of treatment for SRS, not SBRT.
Mm-hmm.
So Winston Lots is done as part of for the standard machines as part of our monthly QA. Where we're checking MLC and other things following the AAPM TG 142 protocol. There's something called the AQA. Are you familiar with the AQA tool, Natalia? This was an initiative that came out of University of Michigan, and actually our chief of clinical physics, John DeMarco, is involved with AQA. So he has the physicists run the AQA. So AQA is basically a series of tests that you can do with the MLC. It's a variety of automated tests that they just load in to your system, and then you can just run them in a sequence. It looks at a variety of things like the MLC position, SAG, gantry SAG, and other table parameters that is run through the EPID imager. And
Mm-hmm.
it used to be they had a server at the University of Michigan. You upload your data, it analyzes your data, gives you trends and so on. So those kinds of things are helpful. Certainly, if you can find resources to those things that are helpful. But from a operational perspective, the SRS, service is done. If we're doing SRS, we will do the Winston loss on day of treatment. And keeping track in a proactive way, your engineers can help you with checking, with doing checks remotely of things like your motor currents and things to be proactive to change out motors when needed.
Mm-hmm. Yeah, we're doing Winston lots on all of our three true beams daily. Then
Oh,
the images are automatically uploaded and analyzed with
right.
sound check. So that's nice that it's automated.
Right, right. And
Otherwise,
you're
it's
doing it,
tedious.
but are you treating on all those machines with radiosurgery?
Not necessarily, but we do
Oh,
treat a lot of SBRT patients. I would
right.
say probably 1/3 of our patients are SBRT.
Yeah, and that's true for us. But that's a really great practice to do it every day.
Mhm.
Yeah.
I see question from Nadia Honcharenko. Nadia, do you want to turn on your microphone and ask a question?
Yes, hello. I want to
Hello.
send you greetings from Kyiv, Ukraine.
Hello, Nadia.
Here
Oh,
we are.
nice.
It is really a great lecture.
Thanks
I
so
want to
much.
thank you for this confidence. I really appreciate this. And my question is, what is the right prescription for SRS treatment and the objectives we want to achieve? You know, sometimes doctors just prescribe like 21 gray to this PTV, and we don't know, it might be 21 for PTV or 21 100% for GTV, or it should be 24 at GTV and 21 to PTV, or maybe 80% of dose I know sometimes prescribed to PTV. What is your practice about it?
Yeah, this is a great question because I think the field here recognizes the need for this kind of thing too. And there's a fair amount of variation in how this is done between different hospitals. But our physician team years ago put in, because of this reason, a very clear requirement for the prescription. So you have to define the GTV or CTV. You have to define your PTV, and you have to give us the margins that you want. And you have to tell us what dose you want. Is it to the CTV? Is it to the PTV? So the very clear definition. You can have a template really for what the prescription should be. And you know, a lot of times those are informed by the protocols, the clinical trials, or the protocols that they'll use to say, okay, I'm giving 18 times 3 to the 95% line on the PTV. You know, so it's very clear when the planner goes in what they're putting in for their for their prescription doses as well as their dose constraints. And we also require the physicians to give us their recommendation for IGRT. What would they like? Are they wanting daily cone beam CTs? Are they wanting, you know, weekly cone beam CTs and KV every day or something like that? So I think the more detailed they can be, the better it is, and they have to do it because otherwise this could lead to a lot of discrepancy and confusion about what targets you're treating and what dose you're giving to your target. Because a lot of times you're doing SIB, right? Simultaneous integrated boost too. And there it becomes even more important that you have very specific requirements on your targets and multiple targets in some cases.
And Nadia, your question was on brain SRS. Did I understand it correctly? Brain SRS in
Yeah.
particular?
Mostly,
Yeah.
yeah.
Mostly.
And brain SRS, typically there hasn't been a margin, right? You know,
Yeah.
a lot of physicians just treat to the GTV, but we actually ask them to think about margins because there is uncertainty. For instance, your image registration is not perfect.
Yeah.
So, you know, we often will have a 1 or 2 millimeter margin, depending on the type of case, and our physicians will accept that, and they'll say, okay, deliver, you know, your dose to the margin, the PTV, the GTV plus the 1 or 2 millimeter margin. But a lot of times it's just the GTV, and I think again clarification on that is going to be important with your physicians.
Yeah, and we will have
It's
a
happening.
lecture on SRS brain, so there will be more
Mhm.
details, so how people prescribe, and it depends on your technology also, what you're
Yeah,
using, right? What
absolutely.
Mhm.
margins to put.
Yeah. And your heterogeneity. You know, oftentimes with brain, you want a hotspot, you want that's over 20%, certainly lung SBRT, you want it to be as hot as you can inside the GTV. So they'll say prescribe it routinely to the 70 or 80% line for lung SBRT.
Mhm.
Okay, thank you. And one more small question about what margin, for example, you use, MLC margin, I mean. Uh, because we usually use DCAT still for these treatments in brain. And I know that margin 1 mil for this treatment is like a cyberknife standard, but when you do the higher margin, we not able to create this high maximum in center. Yeah.
Yes,
Yes.
correct. Yeah, because when you use a large margin, I mean, if you think about it, the source size is about 1.5 millimeters, projects to about 5 or 6 millimeters at the patient, right? So if you want to, a large field, like if you're doing a 3D or IMRT, you would use 5, 6 millimeters to cover the penumbra. But with radiosurgery, as you know, you actually want that margin to be smaller, sometimes even negative, so that you can shoot up the dose, in the target.
Mhm.
Heterogeneity gets very high, and actually it helps you with fall off too, right? Because you're normalizing inside, so that the dose becomes sharper in the fall off. So you're correct. You want a very small margin, or in some cases, negative margin, depending on the type of treatment, to drive up the hotspot. So you're not, I mean, from a geometric perspective, to cover the full penumbra, you want 5 to 6 millimeters, but that's in a standard setting. In SRS, SBRT, I think you want a much smaller margin, 2 to 3
Well,
millimeters or less.
yeah.
Okay. Thank you.
Sure. Thank you for your comments. Really appreciate it.
Thank you, Nadia. Anyone else would like to ask a question? Oh,
Yeah.
Ruslan, go ahead.
Hi, Fimi.
Yes, we can hear you, Ruslan.
Okay, thank you for great lecture. And my question is about dosimetry. Typically, for big fields where we want to measure PDD or profile, we use a reference chamber in the corner of field. And in Ukraine, we don't have typically some special chambers, reference chambers, for example, out of fields. Yeah. And if we want to measure small field, I think this reference chamber in corner of small field can be a problem. And what we can do in such situation, like a set of measurements or very slow measurements, maybe what you can suggest?
Yeah. I mean, this is a great question that I think is a very practical question that impacts everybody. So you have to be creative, and I think your approach of really slowing down the scan, or even taking point measurements sometimes, depending on what field size, is helpful. Sometimes we found that if you take the detector and you move it up to the top, and put it up at the corner, up by the mylar or something, you can actually get a shadow penumbra effect without impacting on the field, and that's helpful. So as close as you can up to the source by moving the detector, you can help. There are certain type of detectors, like transmission chambers, that allow you to integrate, that I think are offered by Sun Nuclear here, that are special type of detectors that help you with this specific situation, where you don't have to bring them as close to the field, but they integrate, so it'll help you with signal. But also it depends on what type of detector. Using ion chamber, using diode. Diode, you can get away maybe because of very high sensitivity.
We use diodes.
Yeah, so diode is better, where you may not necessarily need the reference, but again, got to slow things down and try to increase your integrating time. But great question.
Yeah, thank you.
Thank you.
Anyone else for question? Thank you, Ruslan. If nobody else, we will thank Dr. Chetty. Thank you so much for such an excellent lecture. We learned a lot, and I really loved that emphasis on safety and culture of safety. That was really inspirational and great. I think it would be very useful for Ukrainians. From the bottom of our hearts, thank you so much for this lecture.
Well, thank you from the bottom of my heart, and I wish you all just all the best. We're hoping and praying the war ends, and that you all stay safe in Ukraine.
Thank you.
Thank you so much.
See you everyone next Tuesday. Bye-bye.
Bye-bye.
Goodbye.